All right, Summer, take it away.
Okay. One sec. All right. So we have a patient with a cheap complaint of flank pain and hematuria for the last 2 weeks.
All right, this is a good place to pause.
No, I actually could take it a little bit further with the
Beautiful.
history of
Let's
present
do it.
illness. So our patient is a 32-year-old female, and she presented to the clinic with complaints of right flank pain and hematuria for the last 2 weeks. It's important to note that there's considerable language barrier, but she describes the flank pain as constant, dulling, that occasionally becomes sharp. And I'm gonna stop here, and we could continue the HPI in a little bit after a little bit of discussion, or do you want to finish it now?
Sure, we can go ahead and discuss what you've given us. This is already a rich aliquot, and then we'll have you give us some more information. So we have a young person, a 32-year-old woman coming in with flank pain and hematuria. That is like kind of subacute in timing, given that it's 2 weeks nature. Well, when it comes to flank pain, I often I think about abdominal pain, especially not in the young people, but in older persons. Sometimes the location of the pain doesn't always correlate with the pathology. So you don't want to narrow too closely, too soon. So in terms of like flank pain, oftentimes when we think about like flank pain in the setting of hematuria, you can think about like stones, and oftentimes we think about like both retroperitoneal diseases and also like oftentimes thinking about the kidneys. But oftentimes, again, thinking about like musculoskeletal, skin issues, again, like thinking about a systemic approach that you can take to flank pain. In terms of like the hematuria, maybe I can just like briefly say how I think about it and then pass the mic to Prof. Raz for more poetry. In terms of the hematuria, oftentimes what I would want to know if it's like gross or microscopic hematuria, and the fact that she's already coming in and saying if she is telling you, oh, I'm having blood with the urine, then it is gross hematuria. But again, like that's something we need to be clarified. And also in a woman who is like menstruating, you always want to think about you're not dealing with a mimicker, and she's like talking more about like vaginal bleeding rather than like hematuria itself. And within like hematuria, then oftentimes the way I think about it is like, okay, goes into the genitourinary tract, right? Starting from the urethra, from prostate to your bladder to the kidneys, and where that lesion might be. All right, Prof. Rez, what are your thoughts?
Well, you didn't leave much for me to discuss. That's a great start. And I totally agree. Like in general, when we're dealing with hematuria, we want to know, is it upper urinary or lower urinary? And I think the flank pain is suggesting that it's of an upper urinary etiology. And already, Sharmin, I'm thinking about the diagnostic tests that are available to us to try to localize the site of lesion. And those diagnostic tests range from CT imaging with specific phases with contrast to really look at that upper urinary system. But the lower urinary system requires a cystoscopy. And I just want to pause and take one step back and say, whenever you're dealing with bleeding anywhere, whether it's petechiae into the skin, whether it's hematuria, hemoptysis, you always want to know what is the platelet count and what is the PT and the PTT, because you just want to make sure there isn't like a significant coagulopathy and then a background benign lesion, and now the patient is having severe bleeding. We actually missed a case. Luckily, this was one of the cases I didn't miss. There's many cases I missed, but not this one, where a patient had hematuria and they had sent a PT, but they never sent a PTT. And the patient ended up getting a kidney biopsy to try to identify the source of hematuria, and then the bleeding worsened. And finally, a PTT was sent, and the patient actually had acquired factor VIII deficiency. So I think it's just a great reminder that the same way you said, is it vaginal? Is it urinary? What does the patient's ability to actually clot look like? Mike, back to you, Summer.
All right, great analysis, great insight. So I'm gonna continue the HPI by saying that the hematuria that she describes is intermittent, and she has not noticed any associated fever, nausea, or vomiting. And when asked, she says that there has been no recent trauma or significant changes in her diet or fluid intake. And that would be it for the HPI.
Maybe Summer, I can just comment for 2 seconds and then you can continue with the rest.
Yes.
This is so fascinating because you're putting a time frame on this hematuria. It's not something that's constant and progressive. Rather, it's episodic. And I've never thought about hematuria that is episodic, but you can imagine any cause of hematuria, I would think, can be episodic, from kidney stones to cancer to various etiologies. And so it doesn't, I don't know, Sharmini, does it do much for you, the intermittent nature and trying to prioritize the cause?
No, I agree with you. There is one, I forget what it's called, but I think in younger men, when they exercise or like stand up too much, they have like more hematuria. But other than that diagnosis, yeah, I agree. I think all of these can be episodic. Yeah, no, Summer, if you want to continue, the other thing that, the other thing that I often look for is like, a fever is weight loss as kind of like red flag symptoms, which I don't think she's experiencing those things. But yeah, Summer, take it away.
All right, so I'm gonna just start with a quick review of systems. And but before that, I want to mention again that there's difficulty to obtain very precise history because of significant language barrier. But her past medical history is actually significant for epilepsy that has been well controlled with valproic acid, and she takes it twice daily and 500 milligrams. And that would be it for the medications. And she has no known drug or allergies. Her family history is non-significant, non-contributory. Both of her parents are healthy, and she has one brother who is also healthy. Her social history is negative for smoking and illicit drug use. And she reports that occasionally, socially, she'll drink alcohol, but nothing too scary. And on physical examination, her blood pressure is normal. It's 135/80. Her heart rate is 78. Her respiratory rate is 16. And she has no fever. Her temperature is 36.8. Her oxygen saturation is 98 on room air, and her general appearance is that of a patient who is in no acute distress. On auscultation, we can see there's a normal S1 and S2. She has no murmurs, rubs, or gallops. and her pulmonary findings are clear. Auscultation is reveals clear lungs bilaterally and no wheezes or crackles. Her abdomen is soft, non-tender, except for mild tenderness in the right flank, but there is no rebound or guarding, and we couldn't palpate any masses. Neurologic examination shows no focal deficits, and the patient is alert and oriented. And I think we're now going to get to the dermatologic findings, which are a little bit more interesting, I think. So the patient has hypopigmented spots on the trunk and the extremities. And she has a flesh-colored papules on the face, multiple ones. And when looking on her lower back, we can see a thickened, rough, slightly elevated patch. And the texture can best be described as that of something similar to an orange peel. And I think I'm going to stop here for now, and maybe you can discuss a little bit more.
And the plot thickens. Absolutely. I'll briefly comment on the past medical history, and then I'll leave the exam for the one and only Prof. Rez. So I think in terms of like the past medical history, I'm thinking about like having a history of like epilepsy. I don't really associate like hematuria. There's no line that I can draw from like epilepsy and valproic acid to hematuria. The only thing that it reminded me of like always think about your mimickers of hematuria, and we talked about one which is like kind of vaginal bleeding. The other ones are like myoglobin anemia, myoglobinuria, like in the with rhabdo that you often see, hemolytic anemias, hemoglobinuria, and those sometimes can be intermittent. And like porphyria is another one that I often think about. Again, like I think it's like quite a stretch. She didn't have any we don't know if she had any history, although I just want to be respectful of the language barrier, which makes this job a job of like getting a history a bit more challenging. So you just like, again, that in itself should like broaden your differential, not limit it, especially if you cannot rely on the history as well as you would want to. So yeah, that was like the only thing that jumped out to me. About valproic acid itself, I'm not aware of any association with any glomerular diseases that oftentimes can cause hematuria as well. But in terms of like a rare side effects of drugs, something to always look up. I've gotten into a habit of like when I pull up a med list and it's a new presentation that I just like either go through it with pharmacy or just like look up meds to be like, hey, can this medication be a culprit? Because we do a lot of things to patients. All right, Rez. Pink Panther.
Well, I changed my name to Pink Panther because Robbie was watching and he texted, "You look good, Pink Panther."
Well, hello, RG.
Sharmiz, I'm going to be honest. So once he started saying the skin exam was interesting, I was like, are we going to see petechiae, and was the hematuria actually GN? And then he started saying a lot of findings that I never think about. Hypopigmented spots, multiple flesh. It sounds like we're doing a USMLE test question. And I'll be honest with you, I put this into GPT and that's what I would do in real life. And GPT did give the answer, but I'm not and I'll just share with you what the answer is based on GPT 4.0. Basically, it said the hypopigmented spots are also known as ash leaf spots. the flesh colored papules are known as angiofibromas, and the thickened patch with an orange peel texture is known as shagreen patch. But the interesting it said when you have kidney, skin, and brain, you should think about a genetic disorder known as tuberous sclerosis complex. And that's all I know. That's where my knowledge of this condition stops. But it actually was going to make this point, like, with epilepsy, in my opinion, as a non-neurologist, it's really a diagnosis of exclusion. You want to make sure there isn't like an intracranial mass or a electrolyte derangement or something in systemically that's driving the person to seize. In this case, I'm sure there wasn't an intracranial mass, there wasn't a substance, but maybe it's a genetic syndrome. I'll love to hear from you, Sharmizi. I don't have any more knowledge about tuberous sclerosis complex beyond the fact what GPT said, it also involves the heart, but it's seeming like a very good diagnosis.
Oh yeah, for sure. And I think her age is also, I think oftentimes people do present in like the 20s and 30s. And, I wonder if this is a woman who already had some like language barrier to begin with, like in terms of like her access to care. And perhaps if this has been going on for longer and she just hasn't been diagnosed with it because of a challenges that she might have faced um, in this arena. But yeah, I agree. I think like majority of it, I don't remember much either, but you do have both CNS disease and I think renal disease tend to be quite common with tuberous sclerosis. But yeah, it's not a diagnosis I've seen since reading about it in medical school.
You know what's so funny? I bet you, Summer, if you presented this to the med students on the chat, they would arrive at it much quicker than I would ever arrive at this diagnosis. Because like literally, I haven't thought about this since I think I presented a case to Robbie of a patient with pulmonary cyst on RLR, and then he went through lymph angiolymphomatosis, LAM, and he mentioned tuberous sclerosis, and that was the last time I heard the word was out of Robbie's mouth, and that was like a year ago.
Yeah. Oh, yeah.
You're 100% right. Yeah.
Yeah, because like cystic diseases or angiomyeloma. Yeah, yeah, yeah. Ah, so good. All right.
So either ask the medical student or ask Robbie.
Our very own ChatGPT 5.0. All right, Summer, tell us more.
All right. So I'm gonna move on to some tests that were run, and I'm gonna start with a CBC. And the hemoglobin was 14. The RBC count was 4.2. The white blood cell count was 6.5. And hematocrit was 37%. And the platelet count was 250,000. And I'm also gonna mention creatinine, which was 1.1. As for the rest of the AST, ALT, they were all normal. All the liver tests function tests were normal. And I'm also want to mention that a baseline creatinine was 0.9. GFR and troponin are normal. And I think I'm gonna stop here for a little bit before moving to the imaging.
Yeah, thank you so much, Summer. And this is such a great case to bring, I think, to VMR, because even if something is rare, it still affects someone. And I promise you, like someone watching this on YouTube, someone in the audience, because of this, they will have, and I don't want to jump to conclusions, but they'll have tuberous sclerosis on their minds. But with this laboratory data, Charmin, I think what it tells me, like looking at the hemoglobin, the platelet, that it's not like an issue with thrombocytopenia. And the patient's not bleeding so much that they're becoming anemic. Because let's be honest, diagnosis is fun, but management is important. I'm on med consult right now. Someone has nausea, vomiting, abdominal pain on the psych ward, which is outpatient. I have to make the decision. Do they need to be admitted to the hospital for IV fluid? But this patient, it's like these are reassuring signs, and it's keeping in line with intermittent episodes of hematuria, and the albumin is normal. Now, contrast that with another patient I got consulted on with very low albumin and a distended abdomen. We CT scanned that patient, and unfortunately, they had metastatic disease everywhere. But the albumin was a clue to sort of a chronic inflammatory process. So I think what these labs do for me is just provide reassurance that this process is not like an acute, hyperacute, progressive thing that I need to think about. How do I manage the hematuria? Am I going to put in a Foley with continuous bladder irrigation? Am I going to have to use formaldehyde? Am I going to have to reverse? No, I'm calm. I'm using GPT 4.0 and my best friend Sharmizi to help make progress. But I would love to hear from you if there's anything else you conclude from these labs.
Yeah, that was exactly the thing that jumped out to me. And I'm like, oh, the hemoglobin is stable. Because, whenever we think about like acute bleeding, for so long, hematuria was the one that I just never remembered. And once you actually see people lose a lot of blood with gross hematuria, then it humbles you to always remember it. So the fact that, yeah, that hemoglobin is stable, it's a good sign. Again, you still want to trend, you still want to make sure, she's not hemoconcentrated for any other reason. But yeah, I think as Prof. Rez mentioned, that it really just affects your plan, that you're like, oh, I have time to think about these things. The other area that I always, honestly, I live in is like always fear of like missing something. So I'm like, what else can I be missing in this case? And again, it looks like, this is a compelling case for a genetic disorder. But again, a 30-year-old can still get kidney stones. A 30-year-old can still get pyelonephritis. Again, with lack of fevers, like leukocytosis, that is a lot less likely. But you just like want to make sure that, this is not another common etiology of hematuria. I think, especially when I don't know enough about a disease that is rare, then I think the path to that is always a typical presentation of like common diseases. So you always like want to make sure there's like nothing else from the hematuria perspective. So like getting your UA, looking at, make sure there's no like, the fact that the kidney is okay points you away from like some of the glomerulonephritis things that we worry about. But also like making sure, in terms of like other non-glomerular injury, like doesn't seem like she had a kidney trauma that would like cause that. So again, just like kind of being like thorough in your workup. And the last thing I would mention, Summer, you mentioned like, the barrier in terms of like a language barrier. This is the case that, I would do anything in my power to, if there's a language barrier, trying to get a hold of an interpreter, even if it's not, because I know like tuberous sclerosis can cause some disabilities in terms of like cognitive disabilities. So you just want to make sure that, you want to distinguish between, are you dealing with like a cognitive disability, or is it just a language barrier? And again, like I don't, in terms of like diagnosis, that might help you. And again, to figure out like the extent of like maybe underlying disease that she has.
Awesome. Okay, I'm gonna move on to the next aliquot, which is gonna be urinalysis. And red blood cells, we could see 20 to 50 RBCs per high power field. As for white blood cells, we could see 4 white blood cells per high power field. Epithelial cells, only 1 to 2 per high power field. And there were no casts, no bacteria, and no crystals. And do you want me to continue to the imaging, or we could stop here? Okay, I'll continue. So two studies were done. First, an abdominal ultrasound, and then a CTAP, a CT abdomen and pelvis. On the ultrasound, we could see multiple bilateral renal angiolipomas, and the largest was a 4 centimeter mass in the right kidney, and it had some hemorrhage. And the CTIP confirmed these masses, and there were no additional abnormalities that were found in on CT. And chest X-ray were not done, yeah, and EKG was not done. And so after talking with the translator, actually, I'm gonna stop here and maybe we'll do the last bit at the end.
Sure. Like looking at the UA, again, we had this hypothesis that like, oh, maybe the bleeding is not as bad, and it's kind of reflected on the UA, right? Like we see some hematuria. Like I would probably venture that she's having some microscopic hematuria rather than gross hematuria with this UA. The other thing, again, you don't want to miss is like those mimickers, but it doesn't sound like, there's a discrepancy between the dipstick for the hemoglobin, like the red blood cells and the RBC count. So that's another thing to pay attention to. But again, like it kind of reflects the fact that, she's not severely anemic yet, at least from this. I think Mark, I just saw it on the chat that he brought a really good point that sometimes like if there's a perineoplastic polycythemia, from RCC can drag the hemoglobin up, which is like a really, really great point. Mark, thanks for bringing it up. And I wasn't thinking about that at all. Prof. Rez, what do you think about the imaging?
Yes, I'm thinking we're making more progress towards that diagnosis of tuberous systemic or tuberous sclerosis complex. And I think the point you made was really important. Like, is there an alternative etiology to the hematuria? That's such a wise point, and you don't get distracted by everything else. And I think what this CT scan shows is, I bet you, and I don't know this for a fact, but I'm just speculating here, that those angiomyolipomas, if they hemorrhage, the blood can just leak into the urinary system through the renal pelvis and then the ureter. So now we have like the cause of the hematuria, and it's like those masses on the kidney. And so the question is, what are those masses? And now we say kidney, brain, skin. Now you're making a very strong case. And so at this point, like, you would involve a genetic counselor and a geneticist to sort of help guide you. And like, what tests do you send? Do family members have to be tested? Is there anything that can be done to slow the progression of the disease? Because, there's been so many advancements in medicine in trying to get to the molecular level as to what the lesion is and whether there's a way we can, prevent it from progressing. But I think that's what's beautiful about internal medicine, is that you don't need to know everything. You just have to be able to put the pieces of the puzzle together and know who to involve and to advocate for your patient. Because sometimes maybe a subspecialist doesn't agree with you, but it doesn't mean you have to stop. So I really love this case. And I think for me, the highlight of this case, and we'll hear more from Samer, was your point, Sharmin, just not to be distracted and know that even someone with a possible genetic condition can be at risk of a more common etiology. I think that's such a brilliant point.
All right. And finally, I also just want to mention that after talking with the translator and getting further reports from her doctors, from the doctors that she sees all the time, it was later confirmed that she had tuberous sclerosis that was diagnosed when she was young. And the angiomyomas actually were found, but were smaller a few years ago. and she had no prior complications from these angiomyolipomas. They were asymptomatic previously.
Wow. Yeah, no, thank you so much, Summer, for presenting this case. Because again, it's been a really long time when since I have thought about tuberous sclerosis complex, and as Raz mentioned, like this is why we love VMR, is because it allows us to flex muscles that are a little atrophied. So I know this is really interesting. And Summer, can you share what you learned in terms of like management? As Prof. Rez mentioned, like my understanding of it is a few years old. That is like mostly like supportive and just watching out for the malignancies that are associated with it. Anything else that you learned that you want to share with us?
Absolutely. So these kidney tumors, TSC patients are overall more prone to develop kidney tumors. The most common type is angiomyolipomas, but they're also at slightly higher risks of actual RCCs, renal kidney cancer, renal cell carcinoma. And so what you do is that, unlike the management for AMLs or any kidney tumor in normal patients without any genetic predisposition syndrome, these you do not remove, you just surveil, because it's very common for TSC patients to develop bilateral AMLs all over the kidneys. So if you want to remove them every time, you'll just end up removing the whole kidneys and putting the patient on dialysis. What you do is that you continuously, either using ultrasound or CT, monitor these tumors, but we're often afraid of RCC, renal cell carcinomas, or RCCs, and these you can, a lot of the time, but not always, differentiate from AMLs, because AMLs are fat poor, and you can see this when doing imaging. They'll have a very low percentage of fat as compared to, for example, the most common type of renal cell carcinoma, which is clear cell renal cell carcinoma. And it's called clear cell because under the microscope, the clear cells are white, because they're clear because of the lipid accumulation, which washes off after staining. And you also are afraid, in the case of especially big angiomyolipomas, of hemorrhage, and the hemorrhage can be into the pelvic system, into urine, or it can also be retroperitoneal. And sometimes this can cause an emergency, and the patients will actually present in shock, in hemorrhagic shock.
Wow. Thank you so much, Summer, for teaching us. That was fabulous. Prof. Rez, any thoughts, reflections from you?
No, Summer, how do you know so much about, is this what you're doing your research in?
No, I work in a TSC, tuberous sclerosis lab. My PI is actually a world expert in TSC, and specifically in inflammatory leiomyomatosis. And so I know a lot about this, but within the lab, I mainly focus on two types of kidney cancer: chromopope kidney cancer and translocation kidney cancer. And we study kidney cancer simply because they are more common in TSC patients. But I don't have a lot going on in the TSC side, other than going to clinic with my PI from time to time. But otherwise,
You honestly sound like a world expert. Like 90% of what you just said is brand new to me. So thank you for that. But Mike, back to you, Sharmizi.
I 100% agree. That's one of the many reasons I love VMR. I always learn from all of you. Thank you so much, Summer, and shout out to Parisa for scribing, and Mariana, Mike, to you for the teaching points.
Thank you, Sharmi. Thank you, Reza, for this fantastic discussion, and thank you, Summer, for bringing this case for us. So I have a couple of teaching points for today. So we started discussing this case, and we noticed that the chief complaint was happening for 2 weeks. So we discussed the subacute nature of the disease, and the patient also had flank pain. So at the first moment, we thought if it could be abdominal pain, because in older people, the pain not always correlate with the location of the disease. And discussing the flank pain, we thought that it could be stones or retroperitoneal disease or a kidney issue or a musculoskeletal issue. The patient also had hematuria, and at this point, it's important to differentiate gross hematuria from macroscopic hematuria. In this case, it was probable gross hematuria. And when we have gross hematuria, it's important to clarify if it's not vaginal bleeding in a woman. And then thinking about hematuria, we also have to think if this blood is coming from the urethra or the bladder or the prostate or the kidneys. So we have to think where the lesion is. It could be an upper or lower genitourinary issue, but flank pain is more characteristic of an upper lesion. And another point that was brought up that is very, very important is that bleeding anywhere, it's very, very important to test for platelet count, PT and PTT to rule out coagulopathies and benign causes of bleeding. This patient had episodic hematuria, so we started to discuss the intermittent nature of the disease. And then in the physical exam, we could notice the hypopigmented spots with multiple flesh-colored papules. And with that, we started to think about tuberous sclerosis complex, especially considering the hypothesis of kidney tumor associated with a CNS tumor causing the epilepsy that the patient had as a past medical history. In the physical exam and labs, we had pretty much normal labs. So at this moment, we were not thinking about acute bleeding. So we didn't think about an emergent management intervention. With the hematuria, we also discussed the importance of a UA to assess for important causes such as glomerulonephritis that can easily cause chronic acute kidney failure. So we had to diagnose it very, very quickly. We also discussed that this patient had a language barrier, and it's very important to assess this language barrier because in a context of tuberous sclerosis complex, the patient could also have cognitive issues. So it's important to differentiate from language barrier and cognitive issues. It was also mentioned that the normal hemoglobin could be caused by paraneoplastic syndrome, increasing the hemoglobin. But in the end, we had masses in the kidneys, and then we associated kidneys, brain, and skin, and it was very likely that we were discussing tuberous sclerosis. And then Summer also brought up important pearls about treatment that we have to monitor the renal angiolipomas because there is a risk for RCC, and there's also a high risk of bleeding and hemorrhagic shock for these patients. And thank you very much for this amazing discussion, and thank you for listening to me.
Boom! That was fantastic. I'm just always so amazed about how fast you all can write down the teaching points in such a concise and wonderful way. It honestly makes us sound great. And I'm like, that was fantastic. Thank you so much, Mariana. That was fantastic. A shout out Summer, Parisa, and Prof. Rez. Such an absolute pleasure. Thank you all. See you next time.